Good morning, everyone. Thank you for joining us. We're shifting gears a little bit today with our grand rounds with Global Neuroscience Institute. Today we have with us Dr. Christian Pedersen. Dr. Pedersen comes to us from Denmark, where he did his medical school. He then did his residency in radiology at Mercy Catholic Medical Center, followed by a fellowship in neuroradiology at Yale in New Haven. Throughout his career in education, Dr. Pedersen received multiple awards, including radiology research awards, include Certificate of Merits, Bronze Medal Award, Summa Cum Laude. He was also invited speaker at multiple national and international conferences and meetings. He currently is the co-chair of Quality and Safety Council at Yale New Haven, as well as the preceptor and supervisor for the Quality and Safety Council at Christiana Care. Dr. Pedersen has many interests, including specifically in neuroimaging and dual energy and dual source CT, as well as quality and safety. Dr. Pedersen, thank you for joining us this morning, and we look forward to your talk.
Thank you very much for that presentation, and thank you for the invitation. Also, happy to be here to talk to you about modern neuroimaging. So I hope you can see the screen, and then without further ado, let's get started. So I do not have any financial disclosures related to this talk here. So there are a wide array of modern neuroimaging techniques and ways to study the function and anatomy of the brain. This is just a very brief list here, but there is so much going on right now. It's a very rapidly evolving field. Unfortunately, I won't have time to go into all of these new techniques, but we're going to focus on the dual energy and the dual source CT for this talk here, which is a very exciting new development in CT that is available right now. That is why I chose it also, because it's something that you can benefit from right now. It's already widespread available in the clinical setting, and I think it's an underutilized technique at this point. So I am hoping to show you some examples how you can use it clinically, and then how it can help you manage your patients going forward. So we will review some basic principles behind dual energy and dual source imaging, illustrate some advantages and disadvantages with single source, that is the conventional CT that we use every day, dual energy and dual source CT, and then highlight some clinical applications with cases. But before we get that far, I just want to take like a 10,000 foot overview thing of like medical imaging and why we order things like we do. If you're very early in your career, medical school, you may have like an understanding that, if you're a little bit worried, you order an X-ray. If you're a little bit more worried, you get an ultrasound. A little bit more worried again, you get a CT, and then a little bit more worried again. If you're really, really worried, you get an MRI. So unfortunately, it would be nice if it was that simple, but unfortunately, that is not the case. We have to be a little bit more sophisticated. So let's talk a little bit about what is CT here. CT, the way you know it, it's used with a single beam with a lot of different energies. And when these energies, they enter the human body, they will be attenuated by the tissues. So if this beam gets attenuated a lot, not a lot of the energy will reach the detector on the other side of the patient. And that means that they won't contribute to the images. When not a lot of beams or energies reach the detector, that tissue will be very bright. So this is why calcium or metal, they will absorb all of these energies, and that will be bright. On the other hand, if you send in this polar energetic beam that consists of a lot of low and high energies into something like the lungs that are filled with air, they won't be attenuated by the air, and a lot of these will reach the detector, and then that image will turn black. So that is why the lungs are always dark on CT and the bone is always bright. So basically, CT, if you want to keep it really simple, it just measures tissue densities throughout the body. And then, depending on how much energy gets attenuated, it knows to like create a scale, and then it creates an image based on that. So it has really high resolution. But have you ever thought about why is it that we use CT so often when we're in the body and the chest, but then when it comes to the head and the spine, then we always prefer, or not always, but in most cases, MRI will always like give better information. And have you thought about what if we are looking to work up like a head and neck cancer with a CT? Then the CT neck becomes our preferred choice here. And when we're looking at the chest imaging, then the CT chest becomes the first choice, not the MRI. So why would that be? Yeah, so these are really good questions, and if you can answer these, you have a better understanding of CT than I think many of at least your medical school colleagues, or maybe also your some of your ordering physicians. But the basically the answer to these questions is that the head is enclosed within the calvarium, and the spine is at least like almost completely enclosed by the bone surrounding the spinal canal. So the problem with that is that a lot of the beam gets attenuated by the bone before it reaches the soft tissue in the brain or the spinal cord. So that means that it really loses its ability to differentiate, to make subtle differences in the soft tissue stand out. So that is simply the problem. And the way we most see it, for example, is in the posterior fossa, where you have the very dense petrous bone, the most dense bone in the body. And that will like absorb so many of these like small energies here that we only have the high energies that are left that can penetrate the bone. That means that we just don't see the soft tissues really well. So that is simply why. But in the neck, if you think about it, in the neck, we don't have this like a bony cage around the neck. So here, the tissues are really well displayed with CT. So that's why a routine CT neck, we use that for infection. We use it for head and neck cancer. The CT chest is partially the same story. There's this other argument here that, air is the enemy of MRI. Air creates artifact in MRI. It doesn't make the tissue stand out really well. So that is why for chest imaging, it's almost always CT that's the go-to. The times we use MR for the chest would be something like cardiac MRI, or if there's a mediastinal mass where we specifically look at the soft tissue, we don't care too much about the lungs. There have been numerous attempts to make MR work for the lungs, but CT just remains the best choice. And then there's like this a little bit last question here that comes up a lot for both neurologists and those who manage people with stroke and other things. But carotid ultrasound is a good test to look at the cervical arteries, but it has some limitations. It's hard to cover like all of the vessels throughout the neck. And if there's a lot of calcified plaque, it will cause shadowing for the ultrasound machine, so it can't really show the lumen of the vessel really well. So that makes this carotid ultrasound limited, but it's a good screening test for a lot of patients. The MRA here can also show the neck vessels pretty well, but it doesn't have as good resolution as CT. Again, CTA neck is our gold standard for imaging, and that is simply because it has good spatial resolution, so it can show small things like pseudoaneurysms or dissection flaps really well. MRA neck can also be used to these things, but it doesn't have the high resolution that CT does. And just as a last point here, the reason why we tend to use CT a lot for the spine too is for trauma cases. The high resolution is really beneficial because we care a lot about the bone there. We want to exclude fractures, and the high resolution simply helps with that. Here it's not a disadvantage when you look at the bone that a lot of the beam gets attenuated by the bone, because when you're looking at the bone, that's actually what you want. So I hope this like a rough overview of some of the imaging considerations here will be a little bit helpful. It's not that often I have a pleasure of speaking to an audience like this with a lot of clinicians in. So I feel like I wanted to just briefly touch on this before we go to the dual energy. So basically, the basic principles of dual energy is that, as we just talked about, the CT depends on the density of the soft tissue, and then also of the atomic number. What kind of tissue is it that you're imaging? And then you can actually, if you use different enough energies and get data separately from these different energies, then you can actually cause these, you can make these tissues stand out. You can see the difference between the tissues. So that is really an exciting discovery when this was made. But this allows us to make material selective images. For example, we can make iodine selective images, water images, bone images, as long as we use two different enough energies. So this graph here will show you that along the y-axis, we have the Hounsfield units. That's what we measure tissue density in, along with energy around, it could be 80, it could be around 100 kVp. And then along the x-axis, we also have Hounsfield unit, but with a higher energy, 140. And when we register the Hounsfield unit from each of these like tissues, for example, let's say uric acid here, then we get a Hounsfield unit. It behaves like this with this type of energy here. And then if you give 80 to 100 kVp, it behaves like this. And then you can see that soft tissue and uric acid, they are different on this scale here, as are bone, iodine, water, fat, air. So that means we can basically tell you by using dual energy, is this uric acid we have here? We can, so that, if you ever have a patient who has gout or something like that, and you could worry, could it be septic arthritis? You can simply do a dual energy CT scan, and it can tell you, yes, we have uric acid crystals here. This is probably just, gout. It's not septic arthritis, so you don't have to fiddle around with like a small needle in a joint. And the same, we can subtract iodine or bone, and it has like a lot of clinical applications, as I'll show you soon. The only thing with dual energy that we need to have in an image is that we need, in order to be able to subtract, we need at least 3 different tissues, but we will almost always have that, so it's not really a problem. But that's simply based when we do the subtraction algorithm, we need 3 different tissues. So there are different vendors here. As I said, I have no financial disclosures. I have experience with these vendors here, but I do have a personal preference for the Siemens. The Siemens is a little bit, and I'll tell you why. The Siemens is a little bit different structured than the other dual energy machines. As you see here, the energy is coming from 2 sources here. There are 2 sites in the gantry where the beams are coming from. This one has the high energy, and the blue one has the low energy. So basically, you can have different energies coming from each of these tubes. The other thing you can use is you can use this as a dual source, but not a dual energy CT, meaning that you have the same energy, but coming from 2 sources. And I'll show you in a second why that it can be helpful, but it basically means that you can really rapidly scan your patient. It goes like super fast, because now these 2 sources here can help you cover the entire anatomy that you want scanned in a much less time. The other vendor here is from GE, where it has a single source here, but this one can switch between high and low energies. So it switches super rapidly. So as this goes around the patient, this one switches between 80 low energy and high energy, and then it gives you this information from that same tissue with different energies by switching so rapidly. And the last one is the detector-based spectral CT. It's a very elegant solution by Philips. But it uses a single energy just from the source here. So it's a single source with a single polar energetic beam, just like we know it from conventional CT. But the difference here is in the detector layer here. The detector are programmed to absorb different energies here. So this is why you can kind of like get the different data from, like, say, the low energies and the high energies here. So it's an elegant solution, and it doesn't, the advantage with this compared to the Siemens, for example, is that here you don't have your gantry. It doesn't need 2 sources here. So the 2 sources will actually narrow the gantry a little bit. We don't worry too much about that in neuroimaging, because when we're imaging the head just not get big enough that it becomes a problem, and the same with the spine. But if you're using dual energy for, like, let's say, the abdomen or chest, where some patients have a really large abdomen or large chest, then the dual source here may not be able to catch all of the tissue, giving you dual energy for all of the tissue. Someone in the periphery will not get the dual energy. can show you that here. This is a dual source Siemens dual energy scanner here, and the inner tube here has a limitation that you can see with the green circle here. And that means that if your patient becomes bigger than this green circle, some of the tissue in the periphery, for example, this down here in the flank here, won't get covered completely. But for the abdomen and chest imaging, it doesn't really matter that much because this is subcutaneous fat. We're usually not so interested in this. And for neuroimaging, it doesn't really apply because we are interested in the head and the spine, the neck. All of these have smaller anatomic sizes. So we will always be able to get dual energy information from these anatomic areas. So just a little bit to summarize, single source, as we talked about, the conventional single source CT uses a single tube, pull energetic beam, lots of different energies. Some get absorbed, some reach the detector on the other side of the patient. It has an outer tube, 50 centimeters, that allow for even big patients. And you can adjust your energy to one of these levels, but you can only use basically one voltage here, kVp. The pitch is basically tells you how fast you're scanning, and you can set this at intermediate for the purpose of this slide here. And the field of view is large. You can use it for large patient, but you don't get, the disadvantages is that you don't get material separation. And if you compare the speed of scanning with the dual source, it's slower. So if we take dual energy, as I showed you, you can even have a vendor that uses one or two tubes, but they have different energies. So if you have Siemens that uses two tubes, the inner tube is about 33, 35 centimeter in diameter. The outer tube is just like the conventional, about 50. And then you use different energies. It scans a little bit slower when you're using the dual energy. And it has the limitation that you have a slightly limited field of view, but for neuro, doesn't matter again. The advantages is that you can do material separation, and the disadvantage is a little bit slower, a little bit limited field of view. So for these reasons, the slower scan time is mostly relevant if you're doing chest imaging because of the breathing and the cardiac, motion. But for the abdomen, for the neuro studies, typically this is not so much a problem. However, if you do have a lot of problems with like motion artifacts in your CT, or patients who are uncooperative, you have trauma patients, maybe they're alcohol intoxicated, then the dual source really shines because you can use the two tubes with same energy here, and then you can increase the pitch in your scan time. So it goes super fast. If you have a dual energy if you have a dual source CT scanner at your facility, try go down if they're using the dual source with the pitch. It goes so fast. The patient's just like flying through the tube and you're getting images in no time. So it really minimizes the motion artifacts. So at Mercy Fitz, where we have been working with the dual energy for 10 years or so, where we found that it's really good when you have a lot of motion artifacts. So that would be like cardiac studies or chest imaging to minimize breathing artifacts. But you can also use it for trauma cases, if there's a motion artifact there. So it's a really good technique here. And then maybe you thought about how about the dose? You're talking about two energies and all that. Are we increasing the dose to our patients? But actually not, because the net dose that you use in a traditional single source CT, you just distribute them between the high and low energy in the dual energy imaging. So it basically comes out to about the same. This is an abdomen scan here where you see the millisievert here is 14.9. That's the net dose to the patient, and using dual energy, it's 11.6. So it's really not that different. Some of these dual energy scanners can even lower the dose because they have some dose reduction techniques, because they're all quite modern. Some of the older scanners are not so good at this dose reduction. So basically that is not a concern. So basically you divide the net dose on both tubes. So you do not increase your patient dose with dual energy. It's just a different way of obtaining information. All right, so here's for dual source. This is basically what the scanner is doing when your patient goes into the tube. It scans around like this, and it keeps scanning around, and then it acquires information like that. You see this on the left side image here. of this patient here. And as you can see, these gray bands that are around the patient don't really have any gaps in them. So when you use slow scanning time, you're acquiring all this information, but it has a little bit higher dose when you run with a slow pitch, and it also is more prone to motion artifact. But what you can do on your single source CT, your conventional CT, is you can just increase the dose. But the problem is that you have gaps in your information here. You see this here? So it means your images are not going to be as good here, may cause you to miss things. So that's the problem. But with dual source, you see these like two sources illustrated as alternating green and yellow bands. They will simply like complement each other and cover this information in between. So you can maintain a very high pitch, super fast scan time by using this. And again, when you use a high pitch, you can use less radiation, and you have less motion artifact. So really good for motion sensitive exams. All right, so we're going to talk about dual energy in clinical practice. Going to switch gears a little bit, and I'll show you some clinical examples here. We can obtain all of these different maps here, virtual non-contrast, iodine maps. We can remove the bone, so we can better look at hemorrhages. We can remove the bone and spine imaging. We can use monoenergetic imaging to do better vascular imaging, and we can reduce streak artifact using a high energy beam. So we're going to show some examples of this. Just real basic. I promise I'm not going to show you any more body imaging images, but just to illustrate a very basic concept, if you do a CT abdomen pelvis with contrast and you get like a renal lesion like this, we do see them on CT lumbar spine sometimes. So I guess it's in your field of operation here. Sometimes we are presented with a lesion that looks like this, and you see the Hounsfield unit is 86. We can't really tell, is this a malignant lesion like a renal cell carcinoma, or is this like a hemorrhagic proteinaceous cyst? What's going on here? But what you can do is that you can color code your iodine signal that comes from your contrast. You know, remember CT contrast is iodine based. Then you can put that iodine map onto basically a non-contrast image that you can also create. And then you create an iodine overlay image like this. So it basically shows you, this is kind of like where the iodine distributes in the kidney. It doesn't distribute in this lesion. It's not taking up iodine, meaning that, you know, if this was a malignant lesion, it would be a malignant lesion that didn't take up contrast, right? That would be unlikely. This is going to be a benign cyst. So that's basically why we can utilize these images to simply give you more information. Because now we can tell you that this density that we see over here in this lesion here doesn't come from the contrast. It doesn't come from the iodine. So it's something else. It's probably a hemorrhagic cyst or something like that, meaning that we shouldn't worry about the malignancy here. So this is really good. It means that we can reduce the callback rate. We can give you more accurate information once we scan the patient. So and then we can also avoid actually acquiring non-contrast images. If let's say you want to do CT neck with and without contrast for like let's say a salivary gland stone, then you actually don't need to do the CT without part anymore with dual energy, because you can just subtract all the calcium, you can subtract all the iodine, and then you can basically create a virtual non-contrast image. So it's a really elegant solution here. It really doesn't come with any added cost. It's just like better image quality. And so it kind of like shows you that now we can look at these tissues in more detail using CT, something that was typically thought of being like an MR job. You know, MR is really good to look at the soft tissue, but now CT is starting to bridge the gap between CT and MRI by simply giving you more information about the tissues here. So if you create like an iodine overlay image, you can still see, as you can see here, you can still see calcium here on both, because we didn't really subtract the calcium. We just created this iodine overlay image here. So things that would be indeterminate on conventional CT, we can classify right now using dual energy. All right, so this is another example here. This is the virtual non-contrast scan here. Basically, you can remove the iodine from a contrast enhanced study, and then you basically create a non-contrast image from that. And it works just as good as the non-con CT you would get otherwise. There can be some limitations if you don't have complete iodine subtractions, but in my experience, this is extremely rarely happening, and this is a very robust technique. I'm going to show you how that works in the brain in a second. But in this case here, if you just did a routine CT, you would have this density here, and you're not sure what exactly is going on. Is this an enhancing lesion, or is it like maybe a calcified, like a salilith, a salivary stone, but when you just subtract the iodine from this using the virtual non-contrast images, basically you just have a density that persists, right? We know all the iodine is gone, we still see the bone. So this is just ossific density, and this is just a salivary gland stone. So very elegant again, you don't have to worry about that. And it's, I would say it's, once you're familiar with the basic principles of dual energy CT, then you are able to interpret these images also, because it's not rocket science. You basically just need to know what map you're looking at, and this will be listed for you at the bottom of each series. So basically, we can reduce the dose. We don't have to do an unenhanced plus an enhanced CT study. It both reduces radiation cost and time. So that is it's a clear advantage. So let's talk about some stroke imaging here. So we have a patient who comes in here, and there is a low density area here in the ACA territory in the perimedian right frontal lobe near the vertex here. And this is like thought to represent a stroke. So when we treat these, you can do thrombolysis, or you can do endovascular thrombectomies here. Thrombolysis is an effective and applicable treatment for a lot of patients with acute ischemic strokes. But one of the problems is that, it can be complicated by hemorrhagic transformation that is associated with poor outcome and death also. The benefits of endovascular thrombectomy here is that it has a very established role in patients with large artery occlusions. But when the endovascular physician goes into the vessels, they will inject a lot of contrast to be able to see the vessels. And we know in stroke that the problem is that the vessels become leaky. So some of this contrast will seep out of the vessels, particularly in the area that's affected. So when we do follow-up imaging, we oftentimes see a density within this area here. This is a case where interventional interarterial reperfusion therapy was instituted, and about 48 to 84% of cases, so it's very common, we see this density here. And both iodinated contrast can create this density, but hemorrhage can also cause this density here, and that's our challenge. And this happens due to the blood-brain barrier breakdown with the vessels becoming leaky. So differentiating between this contrast staining versus hemorrhage early on in the course of after reperfusion therapy is a challenge, because if we can't tell you that this is hemorrhage or this is contrast, well, are you able to start anticoagulation therapy that you ideally want for these patients? And if you want to add on top of this, some of these patients, when they have endovascular therapy, they have stents placed, and the stents are also an indication to give anticoagulation. So if we could somehow tell you earlier on that this is just contrast staining, you could safely start anticoagulation. You don't have to wait until we can clarify this. So how can we clarify this? Well, we could do the repeat CT in 1 to 3 days. And if this density persists beyond 24 hours, it's more likely that it's going to be true hemorrhage, because contrast tends to wash out a little bit sooner. But waiting 1 to 3 days may be not optimal. It creates a delay in having the diagnosis and then the treatment. So that means you can't start anticoagulation right away. We can do MRI. We can distinguish between iodinated contrast and intracranial hemorrhage on MRI. We can. But with MRI, it's costly. There's a delay. MRI is not so fast as CT. Some of the scans can take 40 minutes up to an hour. And other stat cases may be there. MRI machines are costly too, so your hospital may not have a lot of them. That means that we have to wait until the other stat cases are went through. It's very suboptimal to try and pull patients out of an MRI scanner during a scan. So it has some issues with it. And then the final thing is also the contraindication. Some patients may have devices that are not MRI compatible or that require specific settings, such as pacemakers, cardiac devices, neurostimulators, other things. And then some patients may be claustrophobic. The MRI machine comes closer to the patient. So all of this can cause some problems in figuring out what this density is after reperfusion therapy. But if you do have a dual energy CT scanner at your facility, then you can use this technique to simply differentiate between this. And this is another case with this. This is basically a non-contrast head CT that was performed on a 71-year-old male that presented with right-sided hemiparesis. And if you look it's very subtle here, but there's some blurring of the insula on the left here. You see the insula is well defined. You can follow the cortex around with a pencil here. It looks dense. By the way, the Hounsfield unit density difference between gray matter and white matter is only 6. So these are very, very small differences we're trying to identify with CT. But be that as it may, we can still identify a decent amount of these. But here there's some blurring here, and potentially in the basal ganglia that's not so easy to see. And then this patient underwent reperfusion therapy, and they found a left MCA thrombus, and he was treated, and he had a stent put in that vessel. And then we did a post-procedural dual energy CT head here that basically shows that now on the mixed image here, which is the same image that you will get if you just do a routine conventional CT, you see a density here. And if this was just a routine conventional CT, you would get no more information than just what you see in image B here. And that is like a little bit of an issue, because if I were to see this scan here, I wouldn't be able to tell you, is this contrast staining or could there be hemorrhage in here? But with dual energy, we can do a virtual non-contrast, meaning we can subtract all the contrast that's in the image. And then when you do that, that's your VNC map here. You can see this entire density goes away. So this is just like, this was all contrast. There was no hemorrhage in this. And you can even confirm this if you do iodine selective maps where you can see the density again. So this is simply contrast staining just due to leaky vessels. This means that if the clinicians were able to initiate anticoagulation therapy, which was, not only indicated by his stroke, but also by his stent placement in this case, and they did follow-up imaging here, and there was no hemorrhage in this case. So swift diagnosis leading to swift treatment, leading to better patient outcomes. So that's what we want. So this is another case. I helped establish the dual energy CT scan program for stroke patients at Christiana. They're a very busy stroke center, one of the busiest in the nation. It's down south in Delaware. I was faculty there in neuroradiology for the past couple of years, and helped establish this program. And this is one of the cases from that. So this is again non-contrast image here. We have the conventional CT showing this density. This is the case from before. This was in fact a 64-year-old male who had left gaze deviation, left facial droop, left hemiparesis. But then again, on this mixed image here, you see which is basically similar to a conventional CT head, then you still see that you see this density. And when you do the virtual non-contrast subtraction, you see there's a little bit of persistent hyperdensity in here. So there's only partial subtraction here. So that means that this is suggestive of both contrast staining and hemorrhage. And this patient was followed up with MRI, and you see on the gradient echo here that this susceptibility weighted artifact indeed corresponds to the area that was hemorrhage here. And the MRI sagittal T1 didn't show any density here, just to double check that this is not just cortical laminar necrosis from your infarct, but this was in fact hemorrhage. Yeah. So it also works when there's a mixture of contrast and hemorrhage here. So when can we image? When we want to do dual energy to figure out when there's contrast staining. There's a number of studies here that are listed. Some try to image immediately after reperfusion therapy, and some try to image a little bit later. Some said within 36 hours. But the summary of all these studies is that the technique is just very robust. It's really a good and scientifically proven technique that works. And all of these authors, they basically found the same, that dual energy CT can help differentiate intracranial hemorrhage from iodinated contrast. Very high sensitivity, very high specificity, and it changed the diagnosis for these clinicians, meaning that they could do antithrombotic and anticoagulation therapy very early. So let's move on and see some more cases here, some of the other maps here. This is iodine maps in action, and this is a 10-year-old girl who presented with our right-sided hemopheresis, and we get CT dual energy. This is a non-enhanced CT head here that shows these intraparenchymal hemorrhage here, and there's some interventricular extension. You can see the density here. You can see the layering hemorrhage over here in the right ventricle. Here the blood extends over in the ventricle here. So for these cases, one of the important things we can tell you is that it doesn't look like there's active hemorrhage within this hemorrhage, because if there is, there's a higher risk that this might expand, and you should really keep an eye on this. So a CTA is typically the go-to image here, but as you can see, it's not so clear. This is a CTA image here. It's not so clear from the routine image, which is B here. This is the one you'll be getting if you just have a old CT scanner, conventional CT scanner. It's not so clear if there's any active hemorrhage going on. But if you do iodine selective maps here, you can see this dot here in the hemorrhage really stands out. It's very easy to see, and this is called a spot sign, and it's a discontinuous area of hemorrhage that's typically no more than 3 millimeters. And when we see this is something your neuroradiologist or your radiologist will be looking for in these cases with intracranial hemorrhage. Then if we see this, it's indicative that there is active hemorrhage. So we can tell you, this is a hemorrhage that might expand here. So let's move on to another case. This is an iodine map for another patient with intracranial hemorrhage, a 50-year-old male. He had right-sided weakness for 3 days. And there is a non-enhanced head CT that show this almost circular area of density here, this hemorrhage. There's some low attenuation around it, meaning there's edema around it. And when we do the dual energy CT here, mixed image, which is similar to the contrast, this is from a CTA, then you kind of see that the same peripheral density here exists. And when you do that on the iodine, you kind of again see this peripheral density here. So it just goes to show that there's a learning curve also for your radiologist in learning how to interpret these. This was in fact on MRI, it was shown a little bit better, but it had this low peripheral T2 hypointense rim here, vasogenic edema around it here, and then it had all these heterogeneous but low density foci of signal abnormality within the lesion. So this was actually a cavernous malformation. So this is what it will look like on dual energy if you ever acquire this. This is what it can look like when it is complicated by bleeding. This was a larger one, and this was a case that was confirmed by surgery. The peripheral density and the low density in the center basically shows you that there's probably some multi-stage hemorrhage here. It didn't all occur at the same time, but it occurred in phases here. Interesting case there with cavernous malformation. This is a 35-year-old man who had a renal cell carcinoma and pulmonary metastasis, and then he presents with this area of density here, and this would be like your routine CT here, non-enhanced head CT, vasogenic edema around it. When we did this, this was done as a dual source and a dual energy scan, and you see this density here, but there's an area here that stands out a little bit more here. Hard to tell, if this was your patient, I'm sure you would order an MRI brain to look for underlying lesion, especially given this history here. But actually with iodine overlay images, we can show you that, if we just do iodine images that basically shows you and highlights the iodine here, you can tell you what is actually enhancing, right? Because the contrast, the hemorrhage in itself won't take up contrast, but an underlying lesion will. So that basically shows you that this area up here is taking up contrast iodine. So this is concerning that this is actually indeed the mass up here. And this other density we see is basically the bleeding. We can confirm that if we're doing the virtual non-contrast image, where we will subtract the iodine uptaking lesion here, and then this is basically the hemorrhage. So basically you can get a good overview of what is the hemorrhage and where's the lesion just from CT, right? So now we start to bridge the gap between CT and MRI. This is actually a lot of useful information here. And this was also histologically confirmed to be hemorrhagic renal cell carcinoma metastasis here. This is a 50-year-old. This is one of my cases from Yale. We had this published, but this is a 50-year-old male with a glioblastoma. It was IDH positive, MGMT unmethylated, and you have this almost butterfly appearance here. This was a known case. This non-enhanced head CT shows it like this. And on MRI, it had avid enhancement. You see the enhancement, how much it extends here, and the frontal lobes here crosses the midline. So it's a glioblastoma. But then the patient was admitted, and he had a trauma here. He had a CT chest with that trauma, and he also had a head trauma too. So he had just underwent a CTA chest for full trauma assessment 3 hours earlier, and he did routine head CTs. That was a little bit worrisome that, maybe he has like superimposed hemorrhage with his tumor here. So to sort this out swiftly, we did a dual energy CT scan, and I'm going to show you what the virtual monoenergetic image is, VMI, in a second. But basically, when you look at the iodine map here, there were some areas here that, would be a little bit concerning. Could these be like a hemorrhage, or is this just due to the tumor? Tumor will take up contrast here, but but the density you see around it here maybe looked a little bit more than before. So we're a little bit worried that, could he have hemorrhage, with his head trauma, maybe that triggered some intracranial hemorrhage. But when you do the virtual non-contrast subtraction here, then it looks like that. So if you were to take some answer choices here, you traumatic hemorrhage, intratumoral hemorrhage, traumatic and intratumoral hemorrhage, or contrast staining, you could take a moment to think about what do you think this could be here. And then this was indeed, if you look at this here, the virtual non-contrast image here is very similar to the non-enhanced head CT, meaning that all the iodine that's subtracted was simply just due to tumor. It was not new traumatic hemorrhage. It was just due to tumor and cellularity and recent contrast injection from the CTA chest here. So basically, this was stable findings in the head, so he didn't sustain any intracerebral traumatic injury. Then I want to show you something we also do at Mercy Fitzgerald and other sites right now, where we have bone removal tools from dual energy again. If you have a routine image, you get something like this, and some of these subdural hematomas can be challenging to detect because the calvarium is bright and hemorrhage is bright. Well, what if we were just to create a series where we remove the bone so it becomes like dark like this? You can very easily see and very confidently see the subdural hematoma here, because now it's white with a black neighbor here. So it basically means that you have very good contrast, visual contrast. You can easily see the difference here. It also helps you to identify calvarial lesions too, because there will be soft tissue density. They won't subtract out when you do your bone removal. So very good to identify lesions because the calvarium is very bright. It can be hard to identify lesions. You can also use it in vascular imaging, where you can remove the calcium around the vessels to see how much is actually left of the vessel here. In my experience, I like the bone removal for the subdural hematoma detection. Vascular imaging, I think it's still, it has a role to play, but it's still, it needs a little bit more work to get this very functional. Because the problem is when you subtract some of the calcium, you may subtract some of the vessels too. So it's pretty good, but it still needs a little bit more work. But watch out for that in the future. So another case is a 79-year-old female with acute right hemiparesis. He has multiple densities in the brain. You see these densities here in the basal ganglia, one in the thalamus, and some in the sun and some in the ventricle here. And again, it could be a little bit of a challenge to definitively tell you what is hemorrhage. You know, the interventricular part here is probably hemorrhage, but how much is hemorrhage? And then the density in the thalamus has a rim of low attenuation around it, so it's probably hypertensive hemorrhage here. But what about this in the basal ganglia here? But then again, you can just subtract calcium, clearly show you, and this is basically information you get for free with the dual energy. It's fully automated, doesn't require extra tech work. It's just a scan sequence that gets sent automatically to your imaging system. So now you can see this density that was here in the atrium here subtracts, so the rest is hemorrhage. The hemorrhage in the thalamus, as we talked about, didn't subtract, so that's hemorrhage. And the calcium up here subtracts, so that's just calcium mineralization. So basically very easily and confidently able to tell you what is what here. And yes. I just want to show you a little bit about spine imaging too. We can do bone marrow edema imaging. This is a 72-year-old male with back pain who comes in with trauma. And then you can use your virtual non-calcium to subtract the bone trabecula and just visualize the bone marrow edema, right? This is basically why we're getting MRIs of the spine in the acute setting for some of these patients here. One of the reasons is to see if there's bone edema, is there fracture, are we confident, you know. But when you do that, you can color code the edema. So basically the upper lumbar body look yellow to green. That means there's no edema. The blue here is color coded to represent edema in this case here. And you can see this burst fracture where there's some posterior osseous retropulsion here of L4 has edema here. So that fits the picture. But then you also notice there's some edema in the L3 and L5 vertebral bodies. Now, this could just be due to contusion injuries because we don't really see a loss of height, but it could also be that there's fractures here. We need to take a second look, and there are some subtle fractures here, avulsion fractures at L3 and L5 here. This L1 compression deformity, you can see there's like a little bit of line, there's like very minimal loss of height here, but that didn't have any bone marrow edema, so we can just tell you this is chronic. So you can forget about the H indeterminate vertebral compression fractures that you sometimes may see in your report. If you have this technique here, it can be very confidently tell you if there's acute or chronic fractures, and it can also help you detect occult fractures. You can also use it to look more at the spine imaging here. Oftentimes we get in the ED, we get CT for lumbar spine, for low back pain for 6 weeks. Why these patients go to the ED instead of like getting an MRI as an outpatient, it's always a good question. But this was a 65-year-old male with acute severe low back pain after heavy lifting. And then if you have a facility that is able to do this, you can create a virtual non-calcium image where you basically subtract the bone and then has specific algorithm set up that can show you the soft tissue. So here the discs are color-coded green, and you can see there's some disc protrusions here shown at L3, L4, and L4, L5 here that was not really well seen on a conventional CT here. We're really hard pressed to look at these because, right, the beam gets attenuated by the bone, as we talked about in the beginning of the lecture here. And then, you know, it doesn't really, there's not enough energies in the beam when it reaches the soft tissue in the spinal canal to give us like really good illustration of what is going on here. But with dual energy, and we color code these tissues here, we can make these discs here stand out. So you can compare with the MRI that was done here, and you see it's a very, very good representation of that. Basically, almost as good. You know, the MRI shows you the conus and other things too a little bit better, but this is really it's really exciting technique. So basically, MR confirmed the dual energy scan here, but it's certainly much better than the conventional CT here. So you get a little bit better information for this. Then the virtual monoenergetic images. Again, single source CT uses a polyenergetic beam. So the Hounsfield unit from a tissue represents the effective attenuation at this level. So this is basically what we do with the CT, right? Hounsfield unit is very high for calcium because it absorbs a lot of the bone. For air, it doesn't. So Hounsfield unit is very low because none of it's absorbed. But what if we were to just use a single energy here? And if we are a little bit smart here, we can select one that really makes iodine pop. Now, this becomes a little bit physics, but for the iodine atom, for all kinds of atoms, they have shells around them, like with electrons in them. And one of these shells are called the K shell. And if we are able to pick an energy that has just enough energy to eject that electron from the K shell for the iodine molecule, we can utilize something called a photoelectric effect, which is basically why you see this jump in the curve here. This is where we hit the sweet spot for iodine. This is where we hit the exact energy that's going to allow us to have the photoelectric effect. That means that we can make iodine really stand out by showing the tissue at this particular energy. And that is what is shown on the curve here. So the white circle is over the kidney, where we have iodine uptake because it's the kidney. Then you have a orange curve that's shown by fat here in the abdomen, and then we have urine here, which is close to water in density with the yellow here. And you see when we look at this curve here and we get close to the sweet spot for iodine, which would be about 33, 35, you see these curves are so far apart. When the curves are far apart, that means that you can see it. You can see this difference here. This is the gap here. This is why the kidneys are so bright when we look at these images here. But when you use different energies, as you see, these curves will get closer, and it gets harder and harder to tell the difference between the tissues. So how can we use that in clinical practice? Well, this is a 30-year-old male with headache. If you were just to do a normal head CT, looking at this suprasagittal sinus here is a little bit challenging. I'm not sure I would confidently be able to tell you there's a thrombosis here. But if you have the iodine overlay, and if you use an energy that's close to the K-hits of iodine, so you basically make the iodine that's in the suprasagittal sinus stand out relative to the thrombus here, as you can see, good difference between the white and the yellow curves here. The thrombus is the yellow curve. The white here is the iodine. You see very good separation between the curves at this 50 keV. It would also have very good separation if you were to use 40 or 35, of course. So very good separation here. But if you use like a high energy up towards 180, 190, you see it's impossible to depict the thrombus here. So basically, you can use a virtual monoenergetic image to basically create a very good contrast enhanced image here. And you can even do this in scans that are a little bit poor quality. So it's like a poor man's angiogram. Basically, you get information. You do routine contrast enhanced study. You add this series for free with your dual energy technique, and then you basically get a poor man's angiogram here. So that is really good. So this was confidently diagnosed as a suprasagittal thrombosis in this 30-year-old male. All right, streak artifact suppression here towards the end. We have different energies again. We can use them, and we can just see how they look. And this is with 40, that's the one that really makes iodine pop, 40 and 50 here. But these energies are not high enough to avoid the streak artifact that we oftentimes see in the brainstem due to the energy simply not being able to penetrate the petrous bone sufficiently. But what if we were to use higher energies? We could probably get rid of this streak artifact here, because then the beam would be able to penetrate the bone, and more beams would reach the detector on the other side, allowing to contribute to image information. So this is basically what you see with the higher energies here when we go to 100, 110, 140. Basically, we have higher energy photons that create less scatter when they collide with the hardware, and then we have a better tissue depiction of the brainstem. So let's say you're really worried about a brainstem. Maybe you can work with your radiologist at your site to have a brainstem specific CT head or a CT dual energy, or you can just incorporate this, have this like for free sent to you if you have a dual energy machine, and then you get better image information from the brainstem, where we typically have streak artifact that prevents us from telling you exactly what's going on there. So this is really good for a streak artifact. You can also use it if the patient has metal hardware in the spine. You can use dual energy to subtract the metal and use a higher energy, so it basically gives you more information. So it's really good for that too, for metal suppression. So just here towards the end, some of the advantages with dual energy is that it has improved diagnostic performance. I hope I showed you here. We can better characterize lesions. We can do material separation. We can even reduce the radiation dose, especially by getting rid of the with and without CT studies that you're doing. We can use the virtual monoenergetic to make the contrast pop. So maybe you don't have to repeat an angiogram. Maybe you have enough information. It helps you guide interventions, for example, for the stroke, to tell you if this is like contrast staining versus hemorrhage. It also reduces the callback rate, for example, for that renal lesion that we saw incidentally that you may see on a CT lumbar spine, for example. We can just confidently tell you this is nothing to worry about. You don't have to, your patient doesn't have to go follow up here. And then, so lots of good things with dual energy. Some of the disadvantages is that your imaging facility requires to have more data stored, so it's not an insufficient thing, but so you shouldn't just get like all the dual energy information and all the scans you're doing. It might be a little bit costly, but if you have something that you feel like could help your patients, we absolutely should do it. The dual energy CT in itself is a more modern scanner, so of course there's a cost to this, but if you as clinicians start to see the advantage of this is the way we can get hospital administrators to provide these machines so we can do better imaging for our patients. There may be a little bit of a learning curve if you have a radiologist and clinicians who are not familiar with this technique. Post-processing, it can be automated. It doesn't require extra tech work, so you're not going to have any protests from the techs. Slightly longer scan time if you use the dual energy, but in neuro, it really doesn't apply, or the anatomic areas we're looking at are typically smaller. The limited field of view for dual energy, if you're using a Siemens scanner with two sources, really doesn't apply in neuro either because, again, the anatomy is smaller. And the motion artifact for dual energy is mostly relevant for chest imaging. You can see the motion artifact at the aortic root here compared to a faster acquisition here. But if you have a dual energy, you can use dual source. So any kind of cardiac surgeon or gastro or abdominal surgeon, they should be able to help you put some pressure on your hospital administrators to get this kind of technique because they will benefit from it too. So you're not the only physician group that will have a benefit from this. So some take-home points. Dual energy does not increase the patient dose. If you use dual source technique, meaning you're using two sources with same energy, you can create super fast imaging, very good for motion sensitive exam. Your virtual non-contrast maps, you can make definitive characterization of intracranial hemorrhage possible right there. Your virtual monoenergetic images can use this photoelectric effect to have maximal iodine and really have iodine pop out in your image. Helps you to basically create almost like an angiogram or venogram kind of image just from a routine contrast injection. And then you can use bone removal both to detect brain hemorrhage, but also in vascular imaging. The cousin to bone removal with plaque removal here, you can subtract the calcified plaque to look at vessel stenosis. You can use bone edema maps to facilitate detection of occult fractures and differentiate old and acute fractures. And then just remember that, dual energy CT is basically just an improved version of CT. It's a tool. If you only use it in select cases, you will underutilize the technique. So it's basically just an upgrade of CT. So I know I spent a little bit of time here in the end. I may have not allowed that much time in the end for questions. Apologize for that, but I'll be happy to stick around to take any questions if there are any from the audience.
Thank you, Dr. Pedersen. That was a fantastic talk. I know, at least from our experience in neurosurgery, I think this it can prove very useful, specifically in cases where, just off the top of my head, carotid stenosis, where you have either post-stent or even calcified stenosis, where the regular CT always and even MRA overreads the stenosis due to the artifact from the calcification. So, and
Exactly.
there's a lot of patients who also cannot get MRIs, for example, even for spine, they have pacemakers, batteries, whatever it might be. So again, for our, at least just for neurosurgery, there are plenty of implications that could be very positive to help take care of our patients. And again, unfortunately, we're at the top of the hour. So thank you again for everybody who joined us. I think these talks will be made available online as well for anybody who missed it or want to get more information. And Dr. Pedersen left his email address as well. Appreciate it. for anybody who has any questions or concerns or anything they want to address with him research-wise or clinical-wise. And again, thank you, everyone. And Dr. Peters, thank you for taking your time to give us this talk.
Thank you, everyone, for your attention, and have a good day and a good weekend.
Thank you.